Thank you. It is my great pleasure to present our research here, and I hope I can provide some insights from health services research perspective in terms of end-of-life care. End-of-life care is very expensive, especially for cancer decedents. However, quality of cancer care at the end of life is often suboptimal and highly intensive. Such aggressive end-of-life care is generally inconsistent with patients' preferences. Right now, value-based cancer care is top priority, and as you know, led by Dr. Karen Edison, Smilo is participating in the CMS demonstration project. Okay, oncology care model. Okay, so I hope I can provide some. Our research can provide some insights in terms of quality improvement. So let's look at end-of-life care at Yale Cancer Center. In 2014, 27% of our patients are admitted to ICU with an average of 2.2 ICU admission within the last 30 days of life. 38% had ED visits, 52% had hospitalization, and 18% received chemotherapy. And improving end-of-life care represents an opportunity for both quality improvement and cost savings. So, what can health services research help? Health service research is a multidisciplinary field that examines how people get access to health services, how much care costs, and what happens to patients as a result of this care. It differs from traditional clinical research, which tries to examine the impact of an intervention on health outcomes such as longevity or quality of care. Health services research try to understand how social factors, health policy, organizational structures and the processes, medical technology, and the personal behaviors influence access, quality, and the costs of health care, and the health outcomes, and the interactions between health care and the health outcomes. Today, I want to focus on small area variation or geographic variation. This is not new. Since it has been discussed for more than 40 years, and John Weinberg found wide variation in physician practice patterns. He said, if 10 Bostons could become New Havens, the saving to Medicare would amount to $500 million. That's a long time ago. And he argued that through the retrospective study of patterns of care, optimal treatments would be defined and substantial economic savings would be achieved. And of course, from physician perspective, it's due to uncertainty and the practice style. So actually, small area variation partially has led to evidence-based medicine and guideline developments. But it raised the concern of equity, efficiency, and effectiveness. By no means is high utilization always negative. And variation research has evolved. In the beginning, researchers tried to describe care pattern. For example, using serial Medicare data in 90s, et al. Found that geographic variation in short hospice admission or hospice admission within 3 days of death. And you can see that kinetic is one of the most one of the areas with most intensive care in SEER Medicare data. Right now, researchers try to identify sources of variation. For example, researchers found that inpatients explain most of the geographic variation in end-of-life care. And our group, led by Dr. Kerry Gross, tried to understand differences in treatment modalities and imaging, etc., for cancer care, not necessary in end-of-life care. For example, in breast cancer patients, we found that patient characteristics can only explain 2% of a geographic variation in expenditure in breast cancer initial treatment. However, treatment modality can explain 15% of a geographic variation. This phenomenon is even greater in prostate cancer treatment. We found patient characteristics can explain about 9% of expenditure, and the treatment intensity, like active surveillance and surgery or radiation therapy, can explain 20% of geographic variation. And the treatment modalities, such as robotic surgery, IMRT, can explain additional 30% of expenditure variation. And researchers also try to identify mechanisms leading to the variation. Economists would argue that supply and demand. However, researchers also found that patient preferences actually explain little of geographic variation. Most importantly, it is physicians' beliefs are the main driver. We will talk this issue later on. So since 1999, IOM has several reports on cancer care quality. Palliative care is also one of the important fields. So thanks to the Yale Cancer Center for supporting our research, we conduct a pilot study to examine end-of-life care among cancer decedents. And we use SEER Medicare data 2004 to 2011. SEER stands for Surveillance Epidemiology and End Result. This is a linked data set from tumor registries and Medicare claims data. We identify about 135,000 cancer decedents from 9 common types of cancer who die as a result of cancer. And we use a validated measure regarding aggressiveness of end-of-life care, including chemotherapy within 14 days of death, repeated ED visit, repeated hospitalization, and more than one ICU admission within 30 days of death, in-hospital death, and short hospice enrollment less than 3 days before death. Using the updated data, we can find that despite emphasis of improving end-of-life care, geographic variation in end-of-life care remains. And again, this is New Haven. It's still one of the areas with aggressive end-of-life care. And we can find the trends in aggressive end-of-life care from 2006 to 2011. Any aggressive care means any of the 6 measures we included. It increased a little bit, but because our large sample size, it is still statistically significant. And the most important one is ICU admission and repeated ED visit. And In-hospital deaths actually decrease because hospice use. However, most of them actually is due to their hospice use. And there is no significant difference in chemotherapy use. So how about Yale? Oh, sorry. So how about Yale? So ICU admission is about 27%, and repeated hospitalization is around 26%. Actually, you can see there's room for improvement at Yale. In the areas, we can separate them into 92 hospital referral regions. And we found that only 5 regions, or 5 hospital referral regions, has a decreased trend of end-of-life care aggressiveness. I hope Yale, after the participation in CMS demonstration project, then we can have a decreased end-of-life care aggressiveness. And does it matter? In terms of expenditure? Actually, this slide can show that the differences between patients who receive end-of-life care, aggressive end-of-life care versus those who did not. So the red line represents patients who did not receive aggressive care, and you can see that expenditure actually is banned. And the differences between patients who receive aggressive end-of-life care versus no aggressive care is substantial. $18,700 for the last month versus $4,200. And we can expect that patients who did not receive aggressive care, the most expenditure actually is spent for hospice. So it emphasizes the importance of palliative care referral or hospice referral. And as we can expect, the expenditure for patients who receive aggressive care is to inpatient and outpatient expenditure. And we also try to understand how these measures, quality measures, could explain regional variation. So this is a chart to present the factors that could explain geographic variation between the top quintile areas and the lowest quintile areas. And we can see that, patient characteristics could explain about 15% of geographic variation. Lead chemotherapy or short hospice only explain 1% of geographic variation, and the ICU admission could explain 38% of geographic variation. Combining all 6 factors can explain 63% of geographic variation in expenditure between the top and the bottom quintile areas. So now I want to share my ongoing projects. The first one, 2 ongoing projects. The first one is related to the physician practice patterns. We know physicians practice differently in different geographic regions, and the prior research has demonstrated that physicians practicing in high expenditure regions are more likely to recommend discretionary services for which strong evidence is lacking, or test and treat patients intensively. So I argue that physician practice patterns represent local practice norms, and how the local practice norms modify patterns of care or an intervention's effect in the regional context. So I use hospice use as an example or as an intervention. We expect that hospice enrollment would decrease end-of-life care expenditure, right? And this slide shows the mean expenditure according to HR quintiles and the duration of hospice enrollment. The line with triangles represents the highest quintile, and the line with circles represent the lowest quintiles. And the expenditure is further analyzed or based on the duration of hospice enrollment. And as we can expect, here expenditure would decrease as hospice enrollment duration increases, as this demonstrates. But we can see that the differences between expenditure between the highest quintile and the lowest quintile, and divided by the expenditure in the lowest quintile, is about 60% if patient did not use hospice, or only use hospice less than 1 week. But if patient can have hospice enrollment over 8 weeks, then the difference decreases to about 25% to 30%. And when we look at the hospice, look at the expenditures according to sources, and we can see that expenditures for hospice services actually did not differ between the top quintile and the lowest quintile. It makes sense because hospice expenditure is per diem rate, so it depends on the length of hospice enrollment. However, if we look at the expenditure for inpatient and outpatient, then the difference is huge, and the increase in outpatient and inpatient expenditures in the lowest quintile area could be balanced by the expenditure for hospice. So makes the difference between patient who has some period of hospice enrollment is very small, whereas hospice enrollment, whereas the expenditures for inpatient and outpatient expenditure is so huge that we can see the difference is substantial. And after adjusting for patient and tumor characteristics, we can find that as long as patients have a hospice duration longer than 4 days in the lowest quintile areas, there is no statistically significant difference in terms of expenditure in the lowest quintile areas. However, in the top quintile area, there is substantial variation in end-of-life care expenditures based by the duration of hospice duration. It indicates that physician practice pattern can modify the impact of hospice duration on expenditure. Remarkably, that the expenditure in highest quintile for who did not receive who had long hospice use more than 2 months, actually had incurred larger expenditure than those who reside in the lowest quintile area without hospice use. So this is very important. Also, I want to show you that Yale or New Haven actually is in the area of a high expenditure quintile. So if we can improve palliative care referral or hospice use, we can reduce expenditure dramatically. And this is another project that I'm working on. This is not limited to patients who, it's for not just limited to cancer decedents. It's I use Medicare data in 2011. I try to understand the sequence of transitions in care. So that's in the United States, in the 6 months before death, about 88% patients reside at home, and 20% die without any transition. And they have most of them have had a transition to hospital. Then they can have a second transition, 3 transition, and we can see about 1/3 decedents have 4 or more than 4 transitions in the last 6 months of life. And when we look at the state, Utah, which has not the lowest actually, Alaska is the lowest one. Utah is the second lowest. And we can see that only 22% have more than 4 transitions, and most of them actually had a transition to home hospice or hospital and died without further transition. And if we look at the New Jersey, the state, New Jersey, it has the highest or largest number of transition in care. And we can see more than 37% of decedents had 4 or more than 4 transitions in their last 6 months of life. And most of them actually have transitions from home to hospital, then the second transition to home or skilled nursing facilities, and back to hospital, and have another transition. Okay. So my take-home message is, first, despite growing focus on providing appropriate end-of-life care, there is no improvement in aggressive end-of-life care. And second, patients who receive aggressive end-of-life care incur 4 times higher expenditures than those who did not. And finally, local practice norms matter, and I hope Yale Cancer leaders at Yale Cancer Center can encourage further efforts to increase palliative care or appropriate end-of-life care. And I would like to thank my collaborators, especially Dr. Kerry Gross, and I thank you very much for your attention. I open for any questions.
So before we open the floor, I'm just wondering if Rogerio or I don't see Roy here would want to comment on how these ideas fit with current planning for the Cancer Center or Smilo.
So end of life is a major focus of what we do at Smilo. It's an enormous opportunity, both in terms of quality of care and in terms of moving the platform to a value-based approach. So I think your research helps us understand how we are situated in a national program, and I think, as you said, we hope that in addition to other initiatives that we've taken, that the launch into the oncology care model will help us address these issues a little bit more efficiently.
Okay.
So one of the things that I think was really special about this talk, and I actually didn't know it was coming, was this really shows the intersection between individual institution practice patterns and individual institution culture and national data to show where things fall. And you know, it's really amazing that last part you described that showed all the transitions of care where patients are going from home to hospital to SNFs back to hospital. That's exactly what we see and we describe anecdotally and a little bit with our internal data analysis. But putting it in the larger context, benchmarks to compare is going to be so helpful as we look to really improve what we're doing. So thank you.
There are so many factors in end-of-life care that it's hard, but you've done a lovely job in your address today. A question that I would have, and how this applies to places like Yale, is the phenomenon of taking care of strangers. That is that so many of the patients are referred here. There has not been a physician who knows that patient and knows that patient's family. And in those circumstances, I believe one of the important roles of physicians, and it may sound harsh, in orchestrating a good death is really not possible because one has not journeyed with the patient through an illness. And I believe that there's a real difference in how it is that one can convince a family to move to hospice if one's dealing with a stranger as opposed to journeying with an individual who has seen you as their trusted advisor over the course of their illness. And I would ask the question, have you looked at that factor? The second factor I would ask is, are there different grounds for admitting patients to intensive care units in different institutions? So we have a phenomenal intensive care unit. It's also a very large intensive care unit. Is that a factor? Do we act to send our patients to the intensive care units on a different prompt than other institutions do? Because that number of 1 out of every 4 patients with the malignancy goes to the intensive care unit. It sounds incredible that we would be using that resource for that many patients in this institution, other than we look to the intensive care unit as a sinecure for patients who might get along very well outside the intensive care unit.
Thank you. So I don't have, I think they are very great questions. So for the last one, I think we can look at the different hospitals and to see, to examine the relationships between ICU admission, for example, as well as the institutional characteristics to understand the difference between institutions, across institutions. But we haven't done that yet. And for the first question, yeah, I agree. I totally agree that Yale has a difficult situation that we need to care patients. Actually, maybe Yale is the last hope for these patients. So it's also the reason why 18% of our decedents receive chemotherapy in the last 30 days of life. But it's just and our data does not have that kind of information. Or maybe we can look at that one in the future. But so far, I don't have that answer. But I believe that, physicians here are strangers to patients. But it may be appropriate to have some kind of patient reported outcomes or patients surveys what they want about their end-of-life care, or what they want in terms of treatment, or what their expectation of a treatment at Yale, then maybe it can provide an angle for physician to suggest that there may be another alternative that patient can have a good dying. But of course, I didn't practice, so clinicians may have a better answers than I have.
Okay, any other questions? Well, I'd like to thank both of our speakers for their insightful talks, which really embody the breadth of activities of the Cancer Center. And thank you all for joining us today.